Hi, I'm Jared Yang. I'm from the University of Alberta.
Thank you.
Thanks for giving me the chance to talk about our consensus statement today. I have no conflicts of interest to declare. So in Canada, obesity has been increasing, and it's tripled over the past 30 years. This kind of shows the distribution of obesity in Canada, with much higher prevalences in our northern territories. Due to increasing rates of severe obesity, we've been increasingly employing bariatric surgery. Our most commonly performed procedure in Canada is actually the laparoscopic room-wide gastric bypass, and then followed by the laparoscopic sleeve gastrectomy. So that's different than the rest of the world, which is going towards more sleeve gastrectomy. And bariatric surgery in Canada has increased dramatically. So this is slightly old data, but this is the newest data we have. Between 2007 and 2014, the rates of bariatric surgery have increased 300%. So, these ERAS pathways, like in that previous talk, were developed initially in elective colorectal surgery. And these are multimodal evidence-based approaches that target perioperative care to try to improve postoperative outcomes. And one of the issues is that ERAS protocols are kind of lacking in Canada. People kind of have different strategies in managing perioperative care. So the objective of this study was to develop an ERAS protocol for bariatric surgery in Canada through evidence review and consensus among expert bariatric surgeons in Canada. Pretty much the group of surgeons, they all did individual literature review of different essential ERAS categories. Like search terms include bariatric surgery, sleeve gastrectomy, fast track, and enhanced recovery, as well as terms specific to each ERAS category. And emphasis was placed on recently published systematic reviews, meta-analysis, and RCTs. A consensus meeting was held in Toronto in September of last year, where we had Canadian bariatric surgeons from 6 provinces and 10 different centers reviewed the evidence and discussed kind of their practices. And then they created 14 essential ERAS elements. And then these elements were assessed using the grade system. So this is kind of a summary of the preoperative, intraoperative, and postoperative ERAS elements that were developed. And I'll go through each one. So the first one was pre-admission information and counseling. There's good evidence to set expectations through information and counseling. There's moderate evidence towards prehabilitation, trying to improve functional status, as well as counsel with exercise. And then encourage participation in a pre-surgery weight loss program has good evidence, but patients don't actually have to lose weight. As long as they kind of participate in it, it can kind of sets the groundwork for postoperative weight loss. Regarding patient optimization, patients are to abstain from tobacco for at least 3 to 6 months. Also abstain from excessive alcohol prior to surgery, as long as they're below the Canadian guidelines, which is like 14 drinks for men and 10 for women per week. Chronic opioid users should be assessed carefully with a chronic pain specialist. Like bariatric surgery should improve their pain, like their weight-related pain, but given their chronic opioid use, they may depend on higher opioid doses after surgery. And it's recommended that mechanical bowel preparation is not necessary. It's like an upper GI surgery, so the fecal load is much lower, or the bacterial load. We suggest a low-calorie diet for at least 2 weeks prior to surgery, and up to 3 to 4 weeks if there's a high body mass index. There's good evidence that this shrinks the liver and it reduces the technical difficulty of surgery. Clear fluids 2 hours before induction, at least 6 hours fast from solid food. This is good evidence in colorectal surgery. The consensus statement actually did not recommend preoperative carbohydrate loading. There isn't a lot of evidence behind it, but the recommendation is weak because there wasn't great consensus. Regarding pre-anesthetic medications, avoid anxiolytics and long-acting opioids because they can cause issues with postoperative recovery. Acetaminophen preoperatively for pain as well as postoperatively, and a single dose of dexamethasone was recommended to reduce PONV. For thromboprophylaxis, either unfractionated heparin or low molecular weight heparin was recommended. For preoperative skin preparation, this is pretty standard, like clip rather than shaving, chlorhexidine alcohol rather than iodine povidone, cefazolin was recommended. Like 1 dose had good evidence that kept sustained antibiotic coverage for the entire case. Metronidazole, there were some surgeons that supported metronidazole in gastric bypass or in BPD-DS, but the evidence is quite low and the recommendation is weak. And for any allergies, vancomycin and clindamycin are good options. For anesthesia, the plan is to reduce opioid use, use balanced fluids, as well as short-acting agents, as well as the liberal use of antiemetics. There was no real good role for epidural analgesia in minimally invasive surgery. Intraoperative leak testing was recommended for gastric bypass, but not required for sleeve gastrectomy. For nasogastric intubation, again, this isn't routinely recommended, but it can be helpful during the initial phase for varus needle insertion. Abdominal and urinary drains are not recommended, and they should not be performed routinely. And then for postoperative prevention of ileus, avoid fluid overload by resuming oral fluids early, as well as early discontinuation of IV fluids and early ambulation within 4 hours of surgery. For postoperative pain control and postoperative nausea vomiting control, again, minimizing the use of opioids is important. The use of acetaminophen as well as short-term NSAIDs is recommended. NSAIDs do increase risk of marginal ulcers, but in the short term, the consensus is that the risk is low. And then patients can go home with a short course of oral opioids, and then you may crush pills as needed. And then the liberal use of antiemetics is important, at least from 2 different classes, Gravol, dancetrone, or dexamethasone. And patients should resume clear fluids the night of surgery and a full fluid diet on post-op day 1. This is a pretty standard practice, but the evidence isn't actually that strong. And for discharge, as long as we have normal hemodynamics, good pain control, good tolerance of the diet, are ambulatory and agreeable to leave, then discharge on post-operative day 1 or day 2 is reasonable. Most centers were performing blood work on post-operative day 1, although a couple of centers didn't, but blood work as needed. And then close follow-up with a telephone call within the first 48 hours was beneficial, and then early clinic follow-up at 1 month and then at 3 months. Again, there wasn't good evidence for any of this, but this is kind of standard practice across Canada. So in conclusion, the purpose of the ERAS protocol is to improve postoperative outcomes. These 14 ERAS elements help to develop guidelines that can be implemented and practiced clinically. And the key is that we think that ERAS can reduce the variability in clinical practice across Canada and promote a common perioperative pathway among Canadian bariatric surgeons and centers. I'd like to acknowledge all the members of the conference, the consensus statement.
Thank you. Paper's open for questions.